In this video I'm going to be talking about a presentation we gave at the 19th Asia Pacific Prostate Cancer Conference in 2018 titled Metabolic Deregulation in Prostate Cancer Towards Blood-Based Metabolic Biomarkers for Early Diagnosis of Aggressive Prostate Cancer. I'll talk about what this work studied, what we found, and how it fits into the wider context of what we're doing here at Maxwell Plus. A copy of this poster is available. The link will be in the description, so if you want to read the paper in full, please check that out. So this work was lead authored by Shrigana Shahari, who's an expert in cancer genomics, and he was working with us at Maxwell Plus at the time, studying how different mutations within tissue of cancer samples and healthy tissue could be used to differentiate between likely aggressive cancer and ultimately non-aggressive cancer. So this work looked at two tissue data sets. Cancer Genome Atlas had 498 patients with tissue samples that had been sequenced, and a publication by Taylor's had 215 additional patients, which were used for an external validation of what we found. So to start with what we found, using the information in the mutation data from the prostate tissue, we were able to apply clustering algorithms to form 6 distinct clusters. We found that one of these clusters in particular, cluster 5, demonstrated here in red, had worse prognostic outcomes than the other clusters. And that was shown at a statistically significant level. What this meant was that if you had the mutations present in cluster 5, your chances of aggressive recurrent cancer were much higher than in other groups. To further validate this result, we then tested the same clustering algorithm with the same cluster centroids on an independent data set. Within that independent data set, we saw that the prognostic outcomes for that same cluster remained bad, and again was statistically significant within that cohort. So the interesting thing about this cluster and these clusters that we found was that the mutations happened in the pathways that were involved in metabolism. So that's the processing of carbohydrates and the processing of lipids, fats. And given that surrounding the prostate there is often a layer of periprostatic fat, it was found that when these cancers mutated in this particular way, we hypothesized that having that readily available fat source was part of the reason that they were so aggressive. And this is shown here where we can see that the clusters 5 and also cluster 3 had quite different metabolic levels for both lipids and carbohydrates, and especially compared to normal tissue. You can see big variation there in all of the cancer clusters compared to that normal tissue bucket there on the right. Now, cancers can mutate for a number of different reasons and undergo a number of different mutations. They're not perfectly understood, but the point of this work was to be able to say, can we take those known mutations and find a way to detect aggressive cancer early? Now, because these mutations were in the metabolic pathways, the natural question that we had was, are there other blood-based markers, looking at common metabolic markers, that we can use to form the same clusters? If we can find a way to pick out these patients without needing to do a biopsy, that's a potential non-invasive early indicator of aggressive prostate cancer, something that's extremely valuable. This is valuable because it can help determine if patients are at all suitable for non-treatment options like active surveillance, or in determining the ideal primary and secondary therapy for that same set of patients. So we looked at a third data set of 97 patients and used a similar clustering algorithm to try and find the same groups. And in the end, we did find those same groups. We used the blood-based markers to be able to differentiate them, and we were able to find the same C5 and C3, these clusters that had radically different metabolic pathways, and ultimately showed that they had poor survival in both active surveillance cohorts and were more likely to demonstrate advanced castrate-resistant prostate cancer. So overall, how does this fit in to the wider picture of Maxwell Plus? The Maxwell Plus is all about gathering as much data as we can about patients and using that to tailor an individual pathway about their prostate cancer journey. Right now, we primarily focus on getting men from their very first PSA test through to an early diagnosis, but we're starting to monitor men on the other side of primary treatment. Now, both those men on the other side of primary treatment and as men as they choose between the many options of primary treatment could benefit from additional biomarkers to help them make an informed decision with their doctor. So this work is going to become a bigger part of Maxwell Plus. It will supplement the work that we do today looking at blood-based markers, demographic markers, and medical imaging markers to give us a holistic picture of the prostate cancer risk for an individual and help guide them through an ideal, personalized treatment pathway. We've done further work on this since, showing how this fits into the bigger picture, but this early work really helps set the foundation for what Maxwell Plus has become as a large, multimodality, AI-driven virtual care provider in prostate cancer.